Guys, so our first lecture today is about the muscles of mastication. Muscles of mastication. These are the group of those muscles which are responsible for chewing, movement of the mandible. Actually, it makes all the movements of the mandible, but due to the reason that they make the chewing movement, that's why we call these muscles of mastication. They help in the process of eating by assisting in grinding the food and bringing our upper and lower teeth together so that they can crush our food. The four main muscles of mastication, they originate from the surface of the skull and they are attached onto the mandible, that is the lower jawbone. If we look into the function of the muscles of mastication, they are called muscles of mastication, there are many functions, but mastication is one of those important tasks they perform. So the movements they perform, they are elevation, depression, protrusion, retraction, and side-to-side movement. Three of these main muscles, they are responsible for the adduction. Adduction means bringing the bone closer. So adduction of the mandible, and only one helps in the abduction of the mandible. Abduction means taking the bone away. If we look into the nerve supply and the blood supply of these muscles, so muscles of mastication are innervated by the motor branches of the mandibular division of the trigeminal nerve, which is the cranial nerve 5, and mandibular division is the third division of trigeminal nerve. Main arterial supply is derived from the branches of the maxillary artery. The muscles of mastication are divided into two categories, the primary muscles of mastication and the secondary or accessory muscles of mastication. Primary muscles of mastication are four pairs. They are paired muscles. Masseter, bilaterally. Temporalis, bilaterally. Lateral pterygoid or external pterygoid, bilaterally. And medial pterygoid or internal pterygoid, bilaterally. The secondary or accessory muscles are buccinator. Again, it is a paired muscle on both the sides of the face. Suprahyoid muscles like digastric, mylohyoid muscle. Mylohyoid muscle makes the most part of our floor of the mouth. And the geniohyoid muscle. Infrahyoid muscles are the sternohyoid, sternothyroid, thyrohyoid, and omohyoid muscle. Masseter muscle. Though it is not the largest muscle of mastication, but is the strongest muscle of mastication. If a person is in a habit of clenching, then the effect on this muscle, it will be creating the accentuation or pronunciation of the angle of the mandible. And the angle of the mandible or the jaw angle, it becomes quite pronounced among those people who are in a habit of clenching. It is a thick quadrilateral muscle. It has a superficial and a deep portion. The superficial portion, its origin is maxillary process of the zygomatic bone and the anterior two-thirds of the lower border of the zygomatic arch. The fibers, they pass downwards and backwards, and it is inserted into the tuberosity of the masseter tuberosity or the tuberositas mesenterica at the angle and lower half of the lateral surface of the ramus of the mandible. Deep portion, it is smaller and more muscular in texture. Its origin posterior one-third of the lower border and the whole of the medial surface of the zygomatic arch. Fibers, they pass downward and forward. Insertion is the upper half of the lateral surface of the ramus of the mandible. Function, bilateral contraction. The superficial part will be elevating the mandible and will causing propulsion of the mandible, means forward movement. The deep portion will cause elevation and its unilateral contraction will cause lateral movement, lateral portion of the jaw, lower jaw. Its architecture. The typical pennate structure, these are the zones of the muscular and aponeurotic attachments. The pennate structure allows spread of the infection in the submesenteric abscess. The differential activity of the muscular planes during masticatory function makes it necessary to inspect the anatomical and functional individuality in the diagnosis and treatment of the dysfunctional orders of the masticatory apparatus, TMJD. That's how, standing at the back, bilaterally, we manipulate and palpate the muscle and check its functioning. If there is any hyperplasia, hypertrophy, etc., etc. Temporalis muscle. Though it is the largest muscle of mastication, but it has a very small attachment on the mandible, most commonly on the coronoid process and anterior border of the coronoid, mostly. But a little bit part, it also attaches on the ramus as well. Very little. It is a broad triangular muscle localized in the temporal fossa. Its original, the whole of the temporal fossa and the deep surface of the temporal fascia. Fibers, they converge as they descend and end in a tendon which passes deep to the zygomatic arch. Its insertion, apex and the medial surface of the coronoid process, which is known as crista temporalis, and the anterior border of the ramus of the mandible to retromolar triangle. Temporalis muscle, it has three parts: the superficial, then the zygomatic portion, and the deep portion. So let's see the superficial portion. Its origin, temporal aponeurosis, temporal line, and insertion into the coronoid process of the mandible, this shaded area. Well, the zygomatic portion, origin is superior and medial zygoma and zygomatic arch from here, and insertion is the coronoid process. It fuses with the tendon of the superficial part of the temporalis muscle and with the deep masseter portion rostrally interdigitated with the portion of the deep temporalis part. Then comes the deep portion. Its origin from the bony surface of the frontal, sphenoid, and parietal, as well as with the temporal bones. And insertion, coronoid process, and the ramus of the mandible just caudal to the last molar, that is the retromolar triangle. Fibers from deep part, they interdigitate with the buccinator and the superior pharyngeal constrictor muscle. So here we can see the origin and the insertion of the three parts. Well, if we look into the function, the main function is elevation of the mandibles. That is why it is among those three muscles which we call elevators of the mandible. And that is by the anterior part. Question usually is being asked where they say that the things are slightly different. Posterior part. Posterior part actually causes the retropulsion or the retraction of the mandible. And usually in most of the exams, like of different boards or the different dental councils, they ask about the posterior part, what it does, or which part is responsible for the backward movement of the mandible. So it is the posterior part of the temporalis. That's how in the temporal region, the anterior part and the posterior part of the temporalis is palpated. Again, standing at the back of the patient, and patient is in just a little bit semi-supine position, not too semi-supine position, a little bit retracted from the upright position, and then we can palpate it. Then comes the external pterygoid or the lateral pterygoid muscle. it has two heads. Well, short, thick muscle, conical in form, located in the infratemporal fossa. It has two heads, the upper and the lower, or superior and inferior heads. So the upper head, which we also call the sphenoid head, its origin is infratemporal faces of the greater wing of the sphenoid bone, and the lower one, from which we call the pterygoid head, its origin is lateral surface of the lateral pterygoid plate. That's why named pterygoid. Well, it's a beautiful picture. The capsule is removed and the some of the portion is removed to show you how the lateral pterygoid, it comes backwards and then it pierces through the uh, capsule, it pierces through the articular disc in order to gain attachment to the pterygoid fovea, which is on the anterior portion of the neck of condyle, just below the head of the condyle. Fibers, they pass horizontally, backward, and laterally, as I showed you. Insertion is pterygoid fovea, which is a depression in front of the neck of the condyle. And it passes through the, as I told you, it pierces through the capsule as well as through the articular disc of the TMJ, frontal margin. Usually, question comes that which of the muscles of mastication is in direct contact with the head of the condyle? That is lateral pterygoid. Another question comes that which of the muscle is in direct contact with the articular disc, and that is again the lateral pterygoid. So far, so good. Everybody is okay. Are you guys following me? Yes, no, maybe. Good. Great. Thank you. Then comes the function of this muscle. Bilaterally, if it is contracting, it will cause propulsion, forward movement. And upon unilateral contraction, it will cause lateral movement or lateropulsion. Then comes the medial pterygoid or internal pterygoid muscle. It is actually parallel to the masseter muscle, if we look at it, and they make a sling. If a fracture of the angle of the mandible is favorable, then that sling is going to support it, and we do not have to go for the open reduction and internal fixation. Simply maxillomandibular fixation or IMF or MMF, whatever you call it, that will be sufficient. Thick quadrilateral muscle located in the infratemporal fossa. Again, it has two heads. Origin, tuberosity of the maxilla for the lateral head, medial surface of the lateral pterygoid plate for the medial head. Fibers, they pass downward, lateralward, and backward. Insertion into the tuberositas pterygoides means pterygoid tuberosities at the lower and back part of the medial surface of the ramus and angle of the mandible. This is how it is. It has two parts, the medial part and the lateral part. This is the inner surface of the mandible. As I told you that it is on the inner side of the mandible. Well, if we look into the function, bilateral contraction, propulsion, and elevation, and upon unilateral contraction, it works in coordination with the lateral pterygoid for the lateral movement. So over here, we are done with our first lecture of the day.